very much for giving me the opportunity to have the next 15 minutes going around NCD control and looking a little bit on where I think are entry doors and challenges if we refer to that aspect. So, many of you know these kind of triangles. In the middle you see the health system, the pyramid, along the pillar being population-focused services, then obviously very strong primary care services, and then let's say going to the top to more referral structures and hospitals. On the right side you see how the allocation of funding in many countries works. Most of the resources going into hospital care and being used for hospital cares. We as NCD community would obviously rather favor to having a focus of resource allocation and attention to primary care, possibly also secondary care, so all what relates basically more to the lower end of the health pyramid, so population health, but also primary healthcare services. We have heard since yesterday a lot about global trends in NCD, about the raising concerns, but obviously also in decrease of certain mortality rates in Europe. And I think if you look into that very clearly, we can also be optimistic to a certain extent that many of our concerns are being taken up. Just to put it very simply, people eat today much more diverse food than they have been eating 50 years ago. So that's something we would like for in a public health perspective. Balanced diet, a lot of fruits, a lot of vegetables, and if you would go back 50 years in history, for sure many of us would have much less choice in these aspects. Opposite, we see then also the other tendency, and that's often what we speak about when we speak about NCD control, about also global markets, which sometimes do have other concerns than public health concerns, than NCD prevention. In terms, for example, of nutritional salted or sweetened drinks, or salted nutrition, sweetened drinks, certain actors do have a tendency to work in a certain direction which is not the one of the public health community. Globally said, I think we can make a separation in terms of public health prevention about approaches which we would call population-based strategies. So in other words, creating a favorable and conducive environment for healthy lifestyle behavior. These are measures, they have also been mentioned a lot in the previous talks, which would maybe often go beyond the health sector. So there would be specific taxes, would be policies for salt reduction, measures for salt reduction of food, for less sweetening of drinks, higher taxes on alcohol, etc., etc. But that are measures which are often outside the health sectors. They send back to questions about ministries of industries, private industry obviously very much to an important degree. A second approach, and we know this is extremely important for the prevention of NCDs. So this is an avenue we very clearly have to embark, and I think the previous speakers have made a lot about of these points. So these are measures which are basically good health for everybody. In terms of a second approach, we have the high-risk strategy. So meaning we identify more health sector-bound people at risk and try to early detect their disease. So that would be a classical example would be a high blood pressure. So detecting people having a high blood pressure and offering them before they really have a health problem, offering them certain treatments. So that would be the high-risk strategy. Reaching out to population group we know reasonably well that one day they will develop an NCD. So they are comparatively to the more population strategy, typically a little bit more expensive, and they would offer services and prevention for selected individuals. In that perspective, obviously, it means addressing risk factors. We know again, often these risk factors are not health sector specifically related. Air pollution is very clearly something which goes more to city planning, to environmental norms, etc. So as classical risk factors, but also linked to agricultural practices, pesticide use, noise use, all these elements which come in tackling these risk factors. And we have good examples of what can work out, and then we think we have a range of countries where we have very good knowledge on this. So we have aspects, I mentioned already, working on the food supply chain, countries who have really engaged in salt reduction. They show very good results in terms of primary prevention, but also transportation policies. Others, evidence globally is a little bit less strong. I would here think about more educational interventions. They are, don't misunderstand me, they are important, but the evidence that basically school education programs make really a difference is not extremely strong, or is moderate, let's call it like that. But we have a series of interventions we know they work. That I just come back, also obviously also underlined by the best buys as given by WHO and the global stakeholder landscape. I think on the other side, it's also very clear we all are likely to suffer one day from several NCDs, and not only one, but several. Many of you are still a little bit younger. I have already grey hair. It's getting here a little bit looser in terms of hair, but pretty much sure I will have several NCDs in some years. So, and that will be the destiny of all of us. When you are in that situation, it's very clear also we look for health services. It will not be any longer enough. I will not be happy to say then public health measures are good, but I will need some care there. And so I think it's also extremely important that we think about health service provision for NCD patients. If I look now the best buys, and they have been mentioned many times, I think they are a very important point in terms of policy strategy development, but at the same time, I think reality is much more complex than simply the best buys. Let's say, and it starts, let's say, when we speak about a CBD treatment, it's easy to say, let's say, provide multi-drug, let's say, drug therapy for people with the risk of developing heart disease, the multi-pill approach. It's very easy to say, but you need health services for that, and this needs to then also materialize in specific contexts. And many aspects come in when we refer to that. So in other words, when we speak about treating and care of NCDs, let's say the cost effectiveness lens is a valid starting point, but in reality, the world is much more complex than just cost effectiveness. So let's say it often does not, let's say, relate to more broader elements. Again, in terms of NCDs, and I will get back to you, nurses are, in my opinion, a very important provider for, let's say, NCD care. But how do you label that in training for a nurse in a cost effectiveness calculation, very difficult. How you label in continuous medical education, the cost of such a conference here, a continuous education, medical education conference, how you label that into cost effectiveness calculation. You might gain a little bit more knowledge, but how this translates in improved service delivery for patients, very difficult. So it's also not easy to establish cost effectiveness along people who have chronic multiple diseases. You know, if somebody suffering from hypertension and diabetes at the same time, how you bring in cost effectiveness at that time, very difficult. This to say, I think if we speak about service provision for NCD patients, the world is much more complex than, let's say, simply the best bets. So you need to think about many other aspects. One aspect, obviously, you need to think about is that many health systems in the Balkans, but also in Switzerland, they are not terribly efficient. So you have a lot of, let's say, inefficiencies in terms of service provision, composition of staffing patterns. So many issues you have to think about in dealing with, so to have really effective and efficient primary care for NCD patients. Simply said, you know, you need to think about, let's say, aspects about how people can access a GP, a general practitioner, or family medicine practitioners out of the working hours. Many settings that's difficult because people don't know what to do when it's a Saturday, and that's then naturally they go to the emergency ward if they have an issue. So you need in a certain way thinking about systems, primary care systems, which also allow you service provision out of the regular hours. Another problem we know very well, quality of care in primary care, not only in hospital care, it's also an issue, but in primary care, it's often an issue. This is the results of a meta-study looking about overprescription of antibiotics, and we know very well that, let's say, in primary care, you often have a very high use of antibiotics, much higher than in other levels of service providers. So you need to think about that. It's not enough just saying we have to have poly pills for NCD patients and primary care for NCD prevention, but we need also to look how we can improve current services, how we can improve better quality, how can we do to offer better quality of care. Or another extremely important aspect is the coordination of care. I think we hear afterwards about the integrated care project, working on that dimension, how you make, in a perspective of people-centered care, it's possible that you have a continuity and, I would call now, a case manager of an elderly person with several chronic diseases. And if you look, it's not only the Balkan countries or the countries here in the region, but also very much Western Europe, which struggles a lot about that. Which means, I think, we need obviously to think increasingly also about what are the best and well-tailored primary care delivery models for dealing patients with chronic conditions. Solutions here might not be everywhere the same. If we speak about the rural area in the mountainous places of Montenegro, Macedonia, Albania, solutions might be different than in an urban setting like Pristina or Tirana or Skopje. So there is maybe not one fit-all solution. So you need to think about, let's say, new staff profiles and what they are to do these new staff profiles. And I think here we see in a lot of countries, also here in the region, good progress, and I'm sure my colleague Besim will refer to that also in the case of Albania, where a number of new profiles of health workers have been established, and where experiences are ongoing also with more team-based approaches in terms of dealing with NCD patients. Point here, we need to think about, let's say, the professional cadres we want to have, which are best fitted to offer care for NCD patients. Nurses here will be, in my opinion, essential. Many of these settings here struggle with migration to Western Europe, and so this means in many places you have shortages specifically of doctors. And to be able to reverse that tendency is unlikely, in my opinion. As long as we have such strong inequities in terms of economic wealth, the pressure to go to Western Unit will continue to be massive. Nurses, we know, however, are often those in many settings where much bigger numbers are available, and which, not in all instances, but in some instances, tend to less strongly migrate. Meaning, you have to build on them, and you have to think about how you make them, how you tool them really for service delivery, for NCD patients. Similarly also, you have to think about new models of primary care. And you see here some examples. There is also good documentation on that. And again, you see there is very different directions different countries to take in what they focus on primary care delivery for NCD patients. We have, you see here the names, but we have, for example, France, which currently focuses on what they call centres de santé, health centres, which would be multidisciplinary team, quite large, but also in a team logic, and also giving a strong emphasis to health education, health promotion measures within that settings. Or Australia would be another example, here also very strongly emphasizing on coordinating care with a clear case holder in the center of the chronic care. Yes, by that, Naim, I hope I haven't much overrun, but I come basically to the end. And the idea has been a little bit of that, to give a little bit the entry stage for my colleagues, which will now present. They will dig more concretely in case studies, in experiences here in the region on, let's say, efforts to, and not only efforts, but also results in dealing, in offering better public health services, but also in better offering healthcare services, primary care services for NCD patients. Meaning, we have to do a focus here on public health approaches, but we also have, let's say, to lobby that primary care gets really the funding it deserves, that really there is evolution on workforce questions, nurses having most likely a stronger role in service delivery, then giving more stronger roles specifically in rural areas, and obviously also moving towards more integrated approaches between, let's say, population level, primary care, but then also linking that more explicitly to hospitals and hospital care. By that, many thanks for having me the opportunity to have this some minutes of introduction, and back to you, Naim.